Welcome, everyone. Today is a very happy day for many reasons. As you know, the Sewell Lecture is the most important annual event that we have in the department. And you'll hear soon more about Granville Sewell, what he accomplished, and why we honor him today. But events like this are really full of intellectual energy. They really help us learn our history and legacy to inspire us to reimagine our present and our future. And I want to thank Carlos for using that word. Also, today, this lecture, the Sewell Lecture, is going to be now forever linked to one of the most dramatic experiences that we've faced in the department. If you remember a year ago, the day we were here celebrating the Sewell Lecture, it was an amazing, beautiful day. I think you all remember. We were together. We had a reception. We had a celebration. And that evening, we had a call. And those of you who were together in the call, you remember well. They told us that our grants had been terminated. Most of the grants in the department, including grants training the students, grants supporting our centers, our grants were terminated. But I want to really think in a positive way. And what I want to think is in the way we responded to that challenge. I believe the way we did it really defines this community. We came together, we supported one another, we fundraised to support for the students to be able to attend conferences that summer, even though we didn't know if we were going to be able to allow for traveling. We managed to do it. We supported also for our master students to be able to do their applied experiences. And we became even more creative, more determined. And I know we work very, very hard. I know that working hard is part of who we are in so many ways. So I want to say thank you. Thank you to all of you. It was a hard year. Yeah, thank you. Thank you. But I said earlier that I was very happy today, and I am also very happy today because we have a new dean, and the dean is here with us. And it's a great honor to welcome Dean Jonathan Mermin. And Dean Mermin, thank you for making space in your very busy schedule in these first few days to be here with us today. We really, really appreciate that effort. So for now, I would like to welcome you and just say a few words to the department.
Thank you so much. Well, thank you very much. I think that's part of the job of Dean, is always to have words. And I did want to thank you very much for inviting me. It's really an honor to be here at the Sewell Lecture. It's my first lecture at Columbia University, and it's great that this is the one. And it's also fitting that it's hosted by Dr. Ana Navas-Essien, because you are such an outstanding professor and department chair, and because of the importance for environmental health, for public health. Anytime your friends in epidemiology complain about the challenges of communications and misinformation regarding vaccines, how difficult it is to rally policymakers and the community around a common purpose, you can just look at them and say, try climate change. So, but it's also why strong students study environmental health sciences, and it's also why we are so fortunate to have Professor Carlos Santos Burgoa here with us today for the Sewell Lecture. And I know that Ana will be presenting him more formally in his bio, but I did want to say that there's something particularly special about his career. He's been a public health practitioner and leader, a distinguished scholar, and an educator. And I think it's clear that we all want to be Carlos Santos Burgoa, but we can't. So the next closest thing we can do is listen to his lecture, look critically at his methods and conclusions, because that's what we do, and to welcome him to Columbia, and I really look forward to what you have to say. And thank you, everyone, for having such a wonderful department, and I look forward to meeting you in class and elsewhere. Thanks.
Thank you. Thank you so much for these wonderful remarks. Now I am going to invite Regina Santella. Regina is past chair of EHS. I am very, very honored to follow her steps. And she was also vice dean of the school. Regina has been part of this department since 1984, since 1982. So she really has an unparalleled long view of who we are. Where do we come from, how we've grown, what we've done, how we've changed over time. And also, her generosity and her leadership have really shaped who we are. So thank you, Regina, for coming today. This means a lot.
Thank you, Anna. Welcome to the Sewell family members. It's my pleasure to, again, say just a few words about Granville. So I have to read what his degrees were because I would never remember them. He has a bachelor's degree in civil and sanitary engineering, and then got a PhD in developmental economics from MIT. And then he traveled around the world using his expertise in environmental sciences and economics to work in many, many different countries developing their different systems. He came here to Columbia in 1967 and developed the educational materials for a program in environmental health sciences. And as a result, the department grew and developed. But Granville was a very special person. He had the most wonderful rapport with the students who loved him. He had the most wonderful parties at his house, an big old house in Englewood. And in the summertime, he had a vegetable garden with trellises where the sugar snaps were taller than me. And my children still remember them with fondness. But Granville was really very important in my career because one of the things he did was go around the world and recruit students to our program. And he was in Taiwan and met a student, and although she was accepted into many different schools, convinced her to come to Columbia. And she became my first graduate student, Ling Ling Shea. And through her, I met someone who became the vice president of Taiwan, C.J. Chen, an epidemiologist who was the vice president of Taiwan. And with the work on liver cancer that we developed together, I had an NIH R01 grant for 25 years. Not continuous, it had its non-discussed twice. But that just shows you the role Granville played. He went far beyond what was required and was a really, really important factor in our department. And he passed away way too young. He was only 59 years old when he passed away. And we really, really missed him. But the department, as you can see, has grown and done wonderful with all these other chairs that we've had. I was only an interim chair, so that doesn't really count.
Wonderful. Thank you. Thank you, Regina, for sharing those memories. I think it's so important for us to continue to honor Granville. So now we are going to introduce our speaker. And I think when we hear about Granville Sewell and what he did, the impact of science for society, I cannot think of a better speaker for the Granville Sewell lecture than Carlos Santos Burgoa. And to have a proper introduction to Carlos, I am going to invite Marcela Tamayo Ortiz, an associate professor in the department. Marcela nominated Carlos for the talk, and then there is a popular vote, the faculty vote. Maybe next year we'll invite the students to vote too. I think maybe we should change that rule. That would be really nice. And Carlos was the selected speaker for this year. So Marcela, please come. Thank you so much.
Thank you, Anna, and good afternoon. And I have it printed because I'm not going to remember all these things. So thank you, Dr. Merman, for being here, Dean Merman. I'm genuinely honored and very happy to introduce Dr. Carlos Santos-Burgoa for today's lecture. Dr. Santos-Burgoa is a professor of global health and of environmental health and occupational health at the George Washington University. And I nominated him because of the person he has been to so many of us. A mentor who makes public health feel both urgent and possible. In my own path, he has been an inspiration and a guide, and I know I'm not alone in that. Here at Mailman, we often return to two ideas that shape how we think. Public health is everything, and health is a human right. When I think of someone whose life work truly lives those values, through science, through institutions, and through actions in moments of crisis, I think of Dr. Santos-Burgoa. His work is about protection, how public health systems and regulatory institutions actually function, and whether they deliver equity or deepen injustice. His expertise spans toxic chemicals and their population impacts, environmental and occupational risks, and the public health response to epidemics and disasters, especially in settings where resources are limited and the stakes are high. What stands out most to me is how his work connects big questions to real people. He is leading an initiative called Unlocking Public Health Protection that you will hear more about now, studying how countries design and strengthen their regulatory institutions to prevent harm before it happens. He has also led landmark work on the health impacts of Hurricane Maria in Puerto Rico, helping document excess mortality and, importantly, contributing with partners like the National Institute of Standards and Technology to identify concrete ways to protect communities for future disasters. He continues to push the field forward in occupational health as well. He is developing a long-term cohort of health workers at IMSS, the Mexican Social Security Institute, to study mortality and workplace risks over 2 decades. And in Mexico, he founded the collaborative Mundo Químico, of which I'm a proud member of, advancing policies and surveillance to confront toxic exposures, including the epidemic of children's lead intoxication and other industrial harms. But if you look across his career, a consistent thread is that he shows up when it matters. He has confronted public health crises ranging from air pollution and toxic chemical events to volcanic eruptions, flooding, and pandemics, contributing to responses for H1N1 and COVID-19, including work on excess mortality surveillance and policy decisions when evidence and ethics have to move together. Before all that, he practiced clinical medicine in marginalized communities in Mexico, an experience that I think helps explain the clarity and compassion he brings to public health leadership. He has served as the Dean of the School of Public Health in Mexico at the National Institute of Public Health, held senior leadership roles in the Mexico Ministry of Health, and served as senior advisor and acting department of the Pan American Health Organization. He holds an MD from the National Autonomous University of Mexico and a PhD in environmental epidemiology from Johns Hopkins. He has trained generations of practitioners and scholars, advised dozens of dissertations, and published extensively while earning recognition, including a Distinguished Alumni Award from Johns Hopkins, a Rockefeller Bellagio Fellowship, and election to Mexico's National Academy of Medicine, and the Collegium Ramazzini. On a personal note, I appreciate that he models a full life. He is rooted in family, in friendship, and in curiosity, and he might not tell you this, but he's even taken up flute in later life. So today, it is a privilege to welcome someone who has spent his career turning the idea of public health as a human right into real protection through evidence, through institutions, and through the courage to act. So please join me in welcoming Dr. Carlos Santos-Burgoa.
Amazing. Who's that person that you were talking about? Thank you very much to all of you for being here. I am amazed that this large auditorium has all of you here. Thank you very much for your presence, and thank you for the invitation and for voting for me. These are the two key messages that I want to leave to you very quickly the role of the state in protection. That's the key role of the state. And institutions matter to whatever we do. Okay, so those are two things that maybe in schools of public health we never discuss. What the role of the state and why institutions do matter. We start to be concerned with institutions when they destroy it. I say, oh, what happened? Okay, so institutions do matter. We are in this lecture because of the family of Granville Sewell. What's interesting is the affinity that I have with his personality. He really has these two things that I think are important for all of us here in this audience. One, interdisciplinary work. Environmental health, public health is not a single discipline. You have to work with many other disciplines, and he showed that. And the second thing is the importance of our field for development. And having worked in many countries, he knew that. And that is why he did this economic analysis for everything, because he knew that this was key for development. So let's keep always that in our minds, that what we do is essential for the development of countries, and not only for developing countries, also for high-income countries. If we don't do our job well, we are going to fail in supporting the development of countries. I am really honored to be here. Okay, there have been, I counted 31 lecturers before me, and I happen to know 13 of them. And not only know, like, hey, how are you, but don't work with them. And what's impressive of this set of people is that all of them are strong leaders, all of them have fought, and they show that our work, the work that you are doing, the work that you will be doing, is not a lonely work. We do it collectively. We do it supporting each other. So the commitment that these people had was amazing. And all of them confronted adversity. We are confronting adversity now. Well, all of them did it in their professional lives. And they grew up in front of adversity. Adversity strengthened them. And they gave everything because they were not scared of these real-life hurricanes. They were ready to respond. And that is something that is important. So we're going to talk about what we have to do in the future about public health. At my age, maybe all these kinds of things that brought me into a stage of my life that I have to think carefully of my age. In my age, I can only think about that, maybe reimagine with you about this. But for you students who are here, you are going to be building the future of public health. And you are going to be building the future of this environmental health. So you are going to be the builders. So for me, it is very important to talk to you about this. So we can talk a lot about our current crisis. We can talk a lot about the hurricanes that we are currently living. But I have decided, no, I want to bring you not too far away. I want to bring you, let's say, January 10th, 2029. It's not far. But we agree, it's not far. January 2029. Just imagine any of you could be named the main advisor to the president-elect on public health. So please move away from those storms that we are living now and think yourself sitting at the same table with the president-elect. And the question is, what is the main advice that you are going to give me? What is the main advice? Can you answer that now? Well, they asked me, why don't you talk about your professional life? Well, I could do that. I have had that's true, I have had a very complicated life, very interesting life. I have had experiences in the field and in institutions, in public health, in clinical practice. Something that was central in my professional life is having the taste of discovering a human carcinogen. I never intended to be a researcher, never in my life. But I happened to become one. I happened to be lucky enough to put together the basic science, the epidemiologic knowledge that I had put together, and discovering a new human carcinogen. So one thing that I can tell you from this life is that, again, nothing of this I did it by myself. I always walked with somebody, with a nurse practitioner in the rainforest areas, with indigenous people, with other professionals. This is not a solo practitioner. This is something that you will be supported always in your life. So what I decided is I want to share with you an experience, a continuous life experience that I had almost from my beginning of my career in public health. And from this discovery into the risk assessment and what do you do with that knowledge, and the problems that we confronted with the institutions to deal with that. First, I want to talk to you about that. Then I will take you to the second part, that is basically saying, okay, this is what happened to me in these institutions. Can we understand what's going on that is stopping us from being effective in our public health interventions? So, and at the end, I will tell you about the current efforts that we're trying to do that. And let me introduce you my pet pollutant. Nobody knows about this pollutant, so it's nobody really. I bet who can raise your hand that you know about this pollutant? Okay. Oh, so we have about 10 people. Okay. I'm so glad. Most likely nobody knows about this, but thank you very much. It's a beautiful, simple molecule. Well, this is basically, it's a chemical that is being used to produce many things. The main product is to make rubber tires or rubber products. Okay, so you have it. And the main source of exposure is in the industrial manufacturing. But it happens to be produced at any combustion process. With incomplete combustion, you will get 1,3-butadiene. So think about any possibility of incomplete combustion. I was talking with students about that they were doing work in Ghana with indoor air pollution. Well, because of wood smoke. Well, there you will get 1,3-butadiene. Obviously, with cigarette smoking. At my home, I love to have a fireplace. My wife hates it, and she says, "Why are you using a fireplace if it generates 1,3-butadiene?" And I said, "Yes, no, you're correct." So now it's forbidden at my home, unfortunately. So anyhow, so you have that, but it's occupational, and we have to think in who is most affected beyond workers. And we have to think if this is going to affect children, pregnant women, and all that, and the whole community. So this was my doctoral dissertation. And I did it at Hopkins, and it took me 6 years of this dissertation. It was difficult years from the financial perspective. There was no financing in those years. The Reagan administration came out and cut a lot of public funding. So this history is being repeated. And I just highlight that immediately when I started looking into the basic science of this, I confronted a key problem. The biggest animal study trying to address the carcinogenesis of 1,3-butadiene was flawed in its analysis. They just didn't do a good statistical analysis. And I confronted them and I said, why? Why they did that? They are really, this laboratory, Hazelton Labs in England, they are well recognized global laboratories. Why they did it? Don't tell me that they don't know how to add and subtract. They know how to do statistics. Well, it happened that this study was funded by the industry. And for some reason, it happened to be biased. That was at the beginning of my trying to understand. I was screening all the chemicals in this industry to find out why there was cancer in this industry, and I found this. So, red lights, immediately red lights from the very beginning of my career. We found a 9.4 increase risk ratio for leukemias in this population. This was a major finding. It happens that this study was financed, my doctoral dissertation was financed by industry. They paid Hopkins to do this study. Okay? The moment came, they saw the whole process, they followed the whole process. The moment came that I said, okay, I'm going to graduate. I said, oh, you cannot graduate. Why? Because the dissertation cannot go public. That was an amazing story. I told you about the story about Gene Matanowski, who was my advisor. I had the full support of the school and the university, and I learned about the legal system in the United States. How do you sue as a student, your university, for the university to sue the industry? But people were learning how to deal with private funding of research, because that was not the way it used to be. It's an important lesson. Now that we are having cuts in our public funding, we have to pay attention to the other sources of funding for this. So I learned it the hard way. And it worked very well. We published the data, and eventually it went into the OSHA process, and we passed a first standard in 1994 for protecting workers against 1,3-butadiene, and we reduced from 1,000 ppm to 1 ppm. The standard, it was a dramatic change. Still, after that, several risk assessments started to happen. Peter Infante, he in 2005, after going through the history and those years of several risk assessments, he said, watch out, this process is having a lot of interference from industry. So this is the story of what we did with 1,3-butadiene. 1988, the discovery of the carcinogenesis. OSHA took it, then the International Agency for Research on Cancer started to assess it. The National Toxicology Program was the first one to say, okay, this is a real carcinogen, and later on it classified as a human carcinogen. Further down, it was US EPA who took it over to start analyzing it, and IARC upgraded it from a probable to a human carcinogen. And most recently, TSCA and the European chemical agencies have been discussing it, looking at it, and recently 2 risk assessments, one from ECHA in Finland, and a recent one that was just finished, and I participated in that one at US EPA. The interesting thing is that these are based not in my study, our study was the first one, but the industry took out from Hopkins the whole cohort, took out the data and gave it to University of Alabama. And University of Alabama, Phil Enterline, very well-known epidemiologist, took it over. And one day in the public meeting, before showing his results, he met me at breakfast and he told me, "Doctor, I want to tell you one thing." He introduced himself very humbly. He said, "I'm Dr. Phil Enterline." "Oh yeah, who doesn't know you? Everybody knows you." And he said, I want you to be the first to know that we confirmed your findings. Your findings are confirmed, and it's not only it's correct, but it's still worse than what you found. So they validated our finding. And the power of validation is extremely important for science, for credibility. They were funded by industry as well, but still they came forward and provided that. It's a cumbersome story, but how industry actually interfered in the history of this? Well, I showed you the analysis of the Rodin studies, several of the risk assessments at IARC, at the International Agency of Research on Cancer, the first EPA, they intervened importantly. Only 2 of the epidemiologic studies considered by EPA in the recent risk assessment were funded by government. Only 2. And that is really critical. The argument is, who knows better the industry than the industry itself? And that's true. They know and they have the data from their own industry. But how come we don't have the resources to have an outside analysis of all of this? What happened? A lot of the leukemia risk was confirmed, but other cancers were not identified until very recently. The cherry picking that we can do as epidemiologists and say, okay, I want to include this cancer and this other cancer, I will not include it. The selection of how do you do the exposure assessment, what is going to be your population denominator, and many other tricks that can be done, they were done with this process. So anyhow, an elimination of working errors and all that. So the whole process has been crowded with problems. The EPA Science Advisory Board considered the risk assessment in April of last year, but by November of 2024, the industry assembled and published an independent risk assessment that clearly said that yes, ambient air, yes, there is butane exposure, but there is no excess risk. We found that there is no excess risk. There is no unreasonable risk of cancer or non-cancer effects. And the current standard of 1 part per million is okay. Well, the US EPA risk assessment found that there were occupational risks for leukemias, lymphomas, bladder cancer, and non-cancer endpoints, including maternal and related developmental toxicity. Some of the students are working on developmental toxicity. Well, that is in the risk assessment. Yeah. Those are all the work areas where they found problems, and they are going to act on that. They are mandated to act on this. They didn't find enough data to support a community risk. So the question now is, are we protecting the population that we need to protect? Is it only the workers? Are we protecting those most vulnerable in this process? We have, yes, we have those in the industrial setting, but we have, as I said at the beginning, families, pregnant women, fetus, small children. If we think that we have motor vehicles generating butadiene on the streets, everybody, all of us, when we walk on the street, we get exposure. Doesn't mean that we're going to get cancer, but we get exposure. How much exposure can we eventually get? That is the problem that we have not moved the science forward. What are all the different sources of 1,3-butadiene that we can get exposed over our lifetime? That's the aggregate exposure, and the interactions with other chemicals, that would be the cumulative exposure. So there is technology now. I am really concerned, and some of you who have been in this field for so long, I'm concerned that VOCs, volatile organic carbons, we are hesitant to consider them when we do environmental exposure assessments, community exposures, air pollution exposures, or indoor air pollution, because it's too cumbersome, too expensive, or too difficult. Now we have technologies that really can help us, and I invite you to think about this possibility of having other technologies that can help us to really measure better what is exposure, because we need that to protect, to identify who are the exposed population, how much are they getting exposed, and if that exposure is risky enough. That's something that we don't have now. So this comes now, I told you the scientific problem that I have, and I'm inviting you to address it. But I have another problem. We started 50 years ago the first epidemiologic studies on this. 50 years ago. We were talking sometime that if you have a medicine or a medical product that could save lives, would you wait 50 years? I don't think we would. We would like that, and FDA is trying to expedite all the ways how we provide medical solutions. Oh, but for protecting people, we're waiting 50 years. Why is this happening? And still, we're denying that there is a risk. Still, we have that. Something is not okay with this process. Something is no. It's such a widespread exposure, and we're not getting protected. We are not getting protected. Okay? So here the question is, many of you are researchers. Do we have an obligation to follow up on our findings? And that means not only to see, oh, how many citations I have. Beautiful. Make a bad paper and you will get a lot of citations. Yeah, so it's not citations. You have to follow up on what is the implications of acting on the results that you have. And I think that is a critical factor. Okay? And for this is, who is in charge in case of carcinogens? Who is in charge of really dealing with this? Who is in charge? How can we influence on that? Is there a possibility? And I try to understand this whole process and see if we could be more effective in what I consider our duty to protect against the hazards that we identify, the risks we have. Who is in charge? Well, I asked that. I went to ECHA, to the European Chemical Agency, and at the end of my stay, I stayed several weeks there, and at the end of my stay, I congratulated them. I said, well, you have a fantastic process for risk assessment and providing orientation for risk management of chemicals. Can you tell me, I asked them, can you tell me how many cancers have you prevented? Nobody could answer that. Nobody could answer that. One of the best risk assessment agencies that you can imagine in the world. Okay? And what happens? Well, I said I have to try to understand what happened. Well, 12 countries. I analyzed quickly 12 countries. Who is in charge of having a control of cancers? Those are the ministries of health. And they have their cancer control programs. Who have the responsibility to reduce carcinogens? Oh, everybody else. Not the ministries of health. Okay? It's environment, labor, attorneys. So, in terms of accountability, the ministries of health are accountable to see how the trends go down and how they can do it with a lot of drugs, surgeries, radiation, hospitals. How can we really take them down, protecting people against those carcinogens? That is how we can really. But the problem is that there is no common mission between those two worlds. And if you go to EPA, they will say, our mission is to protect health, blah, blah, blah. And they consider themselves partially a health agency. But they are not accountable for the eventual health impact. And here it says, science to impact. Okay? So I'm using the word impact. There is only one country or one province in Canada that has estimated that they have been able to reduce 7% their cancer because of control of pollutants. So let's try to understand why this happens, and this takes me to the next part of my talk. Okay, what is protection and why I use the word protection? Protection is this, basically trying to avoid that people get sick. Simple. I will not use another thing. And that is by avoiding that they get any exposure. The problem is that there is a systemic deficiency in how we are doing this essential public health function. This is an essential public health function. How was public health born? Public health was born by controlling what Dr. Sewell did, controlling water. That's how public health went. Cleaning the water. Cleaning, having hygienic houses. Okay? So, this is something that we have forgotten to do. And we know that we have interventions to reduce about 75% of the global burden of disease. It's not minimum. 75% of the global burden could be reduced. That's those WHO estimates, if we actually do our job correctly. So this affects NCDs, this affects infectious diseases, this affects all that. And so what we decided is, let's go and try to understand how these institutions work. And I said, okay, let's go and visit regulatory institutions throughout the world. I was very ambitious. I wanted to do, I don't know how, 30 institutions in all the continents. I was unable to do all of that. I just was able to address the Americas and Europe. But I tried to understand the governance, the institutional capacity, their organizational development, their performance. And I tried to understand, okay, I want to go and have a sense of what is going on inside the institutions. I went one by one, a completely descriptive study, just trying to define what happened. It was a total of 13 cases. Institutions in Africa and Asia were contacted, but it was more difficult, and I didn't have the chance to go on that. 4 of the institutions were specialized on chemicals for food, but most of them were regulating everything. Here you have my favorite one, ECHA. I started with that one, and this is the European Chemical Agency, very interesting. It's based in Finland. It is exclusively for chemicals risk assessment, and they have done a lot. It's a completely autonomous, independent organization. It has a very strong organization structure to defend itself or protect itself from private interests, from regulatory capture. So they have that. They do have a very strong communication to society. They are linked to laboratories. They have a huge investment. It's about 60% of their budget goes into IT. So they are investing a lot in IT and all that. 2 problems that I saw. I told you about they don't have impact measurement and crisis. They're not ready for crisis. Crisis is not for them. We discussed that. Crisis is not for them, and that is a huge problem. Here's FDA, the US FDA. It includes some areas include chemicals. I was working with the food safety branch before it was changed. It's sectorized, but it's autonomous. The problem is that it does not have a lot of interinstitutional work. Neither provides authority to the local health systems. It has a great institutional capacity. They do very good risk assessments. Some relationship with biomonitoring, but nothing really very structural to work on that. But again, their crisis management component is very low. This is Codex. Some of you might have heard about Codex. Believe it or not, this is the agency that determines how international commerce of food happens throughout the world. Everybody in the world uses the Codex as the reference to international exchange. They set the standards for that. Well, you have all the characteristics that you can see, but I'm very much concerned about this point. It has very low structure to defend about capture, regulatory capture. They do not have that. They are not linked to laboratories or other things, and no impact assessment of what they do. But it's a very strong organization. It covers the whole world. Everybody in the world participates on Codex Alimentarius. This is COFEPRIS. This is the Mexican agency, regulatory agency. It's a large federal agency in Mexico. Covers lots of things, food, chemicals, and all that. I would say it's a macro agency. You have FDA, EPA together in this. Just imagine the scope of this. It does distribute authority to the states and share a lot of responsibility to the states and the local authority. But in a country where institutional capture happens a lot, the agency does not have enough organizational, institutional capture structure to defend itself. It is very low on risk assessment. The scientific basis is very low. They don't have enough for a country of 130 million people. They don't have strong risk assessment capabilities. Neither a linkage with biomonitoring that should be part of that, and evidently no impact measurement. By the way, very low transparency and all that. This is a tiny country, Honduras. Everybody thinks about Honduras. Oh, it's a country that has it's a very complicated, high corruption and all that. Well, this happens to be an agency that is autonomous, 100% autonomous. Very interesting. That includes chemicals. Okay, and it has a very acceptable level of defending structure, organization to defend about political and industrial capture. So it is very interesting because it's a growing institution. From a very poor country, they are doing great efforts. So four things that I want to highlight about these 13 countries. Impact measurement, absent basically in all of them. Costing, absent in all of them. Nobody knows why they charge the fees that they charge. Okay? And there is a cost. Go to a hospital and ask them why you are charging this much for this surgery. They will give you a good assessment of why there is a cost. Go to these agencies, all of them, and ask them why you're charging these fees. They don't have cost systems. And you say, how come they are working? Well, they are working with regular funding processes, historic funding. So they don't have that. And the problem is that then they are getting differential attention to the things that they should be giving, especially to the less well done things. Linkage with biomonitoring and surveillance, very little, especially in developing countries. And risk assessment, is really very low. So risk assessment is something, a luxury that only high-income countries have, and it's nowhere in the other countries. So a lot of these institutions are oriented to satisfy corporate needs. Why? Because corporations need to have a license to make commerce. So they work for this. Is this the goal that we want in public health? Is this what we need? Okay. These institutions, given their attention to corporations, they don't pay attention to support small businesses to develop their capacities in this field. So it becomes a structural inequity determinant. By the way, at this point, talking to the heads of these agencies, when I ask them, what is the social value of your institution? They said, well, we're supporting the economy by supporting these corporations that come and require our services. Well, that's not public health value. Is that the public health value? Anyhow, very limited attention to chemical hazards. What's at stake? Well, when governments fail to protect population health, this avoidable morbidity and mortality continues to be there, and the economic and social development of the countries lag. They are really affected. We know that we can. That's why it's called avoidable mortality, because we know that it can be avoided. Right? The economic development goes down. We have health inequities. Public trust is undermined. And trust, as we have learned after COVID, trust is the most important asset that any institution can have. Students, do you trust in your School of Public Health? I think you trust in your School of Public Health, and that's why you came here. Trust is important, and we need to preserve it. And preservation of trust in public health and regulatory capture is always the place. So, what I want to, what we are going to do, and we want to do is, in my last part, is to try to reframe how we're doing this. Shift from the traditional regulatory institution to an effective public health protection authority. Okay, that goes beyond the legal to economic, civic, educational knowledge institutions. An authority built on trust, respect. Okay, that is not only legal. Taking over again the role of the state, the protection, and building institutions for that. So, public health regulatory institutions, these protection authorities, are the critical institution for public health services. So you are in the School of Public Health, and I don't know if you know what are public health systems. But public health systems start with protection, with institutions that provide that critical factor, acting on conditions and risks. Okay? Promotion acts on health, prevention of disease, etc. There you have it. But the first step is protection. And that's something that we have to move forward. So I invite you to do this initiative. And I really invite you. This is something that we are trying to do. Knowing all of this that I have enumerated, we are trying to build this initiative of unlocking public health protection, unlocking public health authorities, trying to reframe how we deal with this I don't have the reframing yet. I'm just telling you about it. It's for you to build it and for us to build it together, okay? To develop the workforce that can deal with this, to build partnerships between all of us. It's not only of high-income countries or low-middle-income countries. It's all of us that have to rethink how we're doing this. We have to do a lot of research on metrics. Artificial intelligence, I think it's now critical here. And engage society. I have not yet found a single person who is ready to go on the streets and shout, I want an FDA, I want an EPA. No, I haven't found that. I want a coffee priest. No, there is no social basis for what we do. Why? We're not telling the people the value of this, the social value of public health. And there is a lot of social value. Their life depends on this. So we have to learn how to do this, and we haven't talked to this. So this is a network that we want to build, okay, with all the ego that characterizes us. We have a GW nuclei, but we're linking with regulatory agencies, to NGOs, to universities, and to professional organizations, and hopefully, eventually, we can put Colombia in that network and work on building this. So, back to the beginning. You have been selected as the public health advisor to the president-elect, January 10th, 2029. You are asked, what is the main advice you will provide? Hopefully, you can remember this slide. I know, we know, currently, we're living in a profoundly turbulent times. Yes, we know it. But only in the deepest despair does true hope arise. And those are words from a German philosopher called Byung-Chul Han. Only in the deepest despair does true hope arise. Characterized by commitment. Hope with commitment to public health protection. Thank you very much.
Thank you so much for inspiring us in this powerful way. I feel that when we look at life expectancy and how it has changed, we should be very proud in public health. And often we can hear, yeah, the hospitals are going to try to take the credit. And so the question is, how can we connect these dots? And how all of these agencies can get the credit they deserved in a way. And also to empower that, yes, we've made, I believe, big successes in many ways, but yes, there is still so much more that we can do for full protection. So I don't know if you want to start, and then after, please, let's start with questions from the audience.
Well, while others want to make a question, this is a very bad slide, a very bad graph, because I'm talking about the public health system, and I just show a line with that. But yes, the first step, I am convinced, the most effective one is the one that protects, okay? And then everything else will follow as a domino effect. Let's think in that way. But really, there are interconnections between all of them. So I would invite this division between personal clinical care versus population protection or promotion is something that does not necessarily help us in understanding the overall impact that we can have. The better we perform here, the better they will perform. Okay, and I learned that the hard way, and we can all see it across the street. The emergency rooms are filled out of things that can be completely preventable, and they should not be working on things that could be taken care of at the primary care level. So you say, okay, so if we do things here well, that part will do their part well. So I see, so that's why I say this is a useful graph to show the continuum of care, but doesn't show all the interconnections that can have. But it's a synergy. I think there is a synergy within all of this.
Thank you. Hi. So you spoke a lot about the concept of regulatory capture, which I'll admit I was introduced to by your presentation today, so thank you. I was wondering if you could tell us more about how, in your research, how did you assess the robustness of those different institutions to regulatory capture? Or maybe put differently, is there a recipe for creating an institution that is successful at centering the public interest and is robust in that way?
You're a student here? Yes. Okay. First step, a student should know about regulatory capture. Okay. That exactly happens at these institutions. When you ask them about it, they just put a what face. What is that? They might know about corruption. And all these institutions, especially in developing countries, are very much aware of corruption. And that's different. Corruption and capture are two different issues. Corruption is money that I am giving and taking and all that, and you are buying the will of others. In this case, you are influencing, in capture, you are influencing how they do the work for your benefit, like changing the information that is going to be used for a risk assessment. That's your, so how the first step on doing this for the diagnosis of an institution is you ask them, do you have any architecture to protect your processes from regulatory capture? And some of them say yes, most of them say no, because they ask, what is that? And so those who say yes, you say, okay, what kind of capture? From industry or for political capture? I would say 99% of the literature talk about economic, private industry, corporate capture, but especially in all countries. I found in developing countries a lot of political capture, you know, the influence of the own government into the agency to change how they do things. So it's a complicated thing, but you can organize it. You can build your processes to protect your people doing this and your final results. And you better make it explicit. It's an organizational issue, yeah.
I have a question. Thanks for the lecture. I'll try to frame this. So you said about social value. So like we have to rebuild public health regulatory institutions so that they have the visible social value. Like, I mean, everyone agrees that they actually already have the social value, but it's not visible. My question is like to whom? Like to public or like those who are voting actually to politicians or to politicians? And if it's either of them or if it's both. And it's like certainly the communication question. So how do you think we should build the communication that faces like those two sides, like both voters and those they are voting for?
Well, when they sit down with these institutions, and because some of them have asked, okay, what's next? Okay, so I tell them, well, you have to analyze your institution and develop an organizational development plan. Okay, so in that process, you identify who are your stakeholders. Okay, those stakeholders, you have to target them, and that's when we have problems, when the stakeholder is only the Ministry of Economics or the corporations. But the social value, by definition, is society as a whole. It's a whole of society value. Okay, and it's not only in terms of reducing mortality, morbidity, or increasing life expectancy. It's how wellness, how quality of life, how productivity increases, and that will be that. Now, then the question is, who is interested on that? Okay, what are the specific stakeholders who are interested in that? And that's where you have to define your different stakeholders that will appreciate that social value. But you know, the whole process of discussing what is the social value at each institution and each country, it's a whole process, a very interesting one. But I said that we have a problem that we don't have a common mission. We are not doing things jointly within the state. You know, the ministries of environment with the ministries of health. We don't have a common mission, and the common mission should provide that social value. It's a common social value. I don't know if I explained you. If not, my apologies.
I'll go ahead and ask a question from Zoom. Dr. Christine Marie George, who is an EHS alumni and professor at Johns Hopkins, asked that we share excellent lecture. I had a question about the training that is needed for the next generation of public health professionals that focuses more on emphasizing systems around environmental health protections.
I don't know what can I answer about that. I truly believe that we need to reinvent how we train this component of the workforce development. Okay, that's the talent development. How the first thing that they have to be trained is understanding that they are part of a system. That they are part of a system that is geared towards protecting people, and so they are not alone in and all these organizations don't acknowledge that they are part of the system. They're very much isolated, and I think that's something, but we have to reinvent it. Well, I don't know if reinvent it, but reimagine that, also how we teach that.
All right, we have another Zoom question. Another alum, Maria Taliero, asks, can you ask, going back to his early years, what would be the advice he wishes he had as a young public health practitioner?
Wow. Wow, that's a difficult one. Well, she made me remember one health leader in Mexico who was very transformative, Dr. Guillermo Soberón. Dr. Guillermo Soberón, I graduated from my PhD in Hopkins, went back to Mexico, and a short time later, I became Dean of the School of Public Health. And I went to see this former Minister of Health. I went to see him and I said, oh God, I got the responsibility of having this to work towards the transformation of the School of Public Health. What should I do? I asked him. He told me two things. One, go and talk to all those who have done your job before. Listen to them. Don't follow them. Do your own path. Bring your own light to this. So this might be against what I am telling you, but I'm telling you that, yes, I'm just giving ideas, but every one of us have to do this. So that is the advice that I am transferring to all of you from my former maestro.
Hi, my name is Julian. So I'm recently working in research and clinical research in a pulmonary clinic, and like throughout college, I first got introduced into the realm of public health. Like before, I didn't know the amount of power it had, and actually I took a course from Professor Nawitza Siang and Professor Sota in undergrad, and I learned a lot. So I just wanted to, it's such a young age, it is hard to grasp how I can impact, do action in public health at such a young age, but perhaps in the clinic, you might have an advice on how, with your experience as a provider, how we can create small habits, when talking to patients, because I see, those interactions on a daily basis, how in those conversations we can, integrate public health, perhaps give, advice to patients of, that's my question to you, how in a clinic we can develop good habits that we can integrate public health, and not necessarily it's in creating policy changes, but just more personal interactions with them. And yeah.
Well, let me tell you, I had the privilege of heading the health promotion division of the Ministry of Health in Mexico. And health promotion has 5 dimensions. The first one is the personal, individual, family dimension. Okay? And that's what you do with education. But you have a second one that is community. A third one that is the setting where you are in. A fourth one that has the intersectoral policies, and the fifth one that is related to what happens in the healthcare units. Okay, so I will tell you a dream that I have. Okay, I have had for many years in relation to your question. Having here these health services, primary health services, empowering individuals and families in making them aware of their exposures. I wouldn't say, don't patronize them, telling them, oh, wash your hands. No. Make them aware of how they are getting exposed. As my wife said, let's shut down our chimney because we're getting particles and butadiene. The same thing, okay? Making them aware so they ask themselves, what can I do? Okay? And empower them with the knowledge for that. I think that is what you can do at the primary care level. And I think that's something that is worthy. But do not underestimate yourself. You might be there on January 10th, 2029.
Hi, thanks for the great lecture. Mark Mataloni, class of 98. So I spent a career at the Environmental Protection Agency, and I would say they did a decent job protecting the public health from environmental contaminants, certainly during the almost 30 years I was there. Now, that has vacillated depending on the administration in power. But how, without disassembling that paradigm, which is to the victor goes the spoils, how do you get to the next level of public health protection?
That's for them to solve it. That's for them to reimagine. That's why institutions matter. Okay, I do think, and there, when I say institutions matter, I am building on 3 economics Nobel Prizes. People who have won their Nobel Prize because they have analyzed institutions. So institutions do matter to whatever they do. So what we have to do is to rethink how we are going to build the January 11, 2029 EPA. Okay, what will be the advice for that? And I think that that my first step will be, what was wrong before? Okay, we don't want to go back to the EPA that we had. It was vulnerable enough to have the problems that we are seeing now. As it happened with CDC, and we have happened with all our public health institutions. Okay, let's learn from this. And as Dr. Sobreron said, don't do that again. Use your light for the future. And I think that we have to build that. I don't have the solution. I'm sorry.
Thank you so much. It's been very, very informative and making us all think hard about what to do about the problem, particularly what we're facing in our country today with the savage rollbacks of our protections of public health, environmental protection. And it seems to me that we failed in terms of educating the public, the people, about the importance of protecting their health environment, their children's health, their future, their grandchildren, so forth, bringing that message home. So we motivate voters to vote for these issues, these issues of protection, which are not even on the list of the main issues that motivate voters. I think climate change is, Brad, you can help me here, but I think it's down toward the bottom of the list, even climate change, an existential threat. So we've got a big job in public education and providing those tools, it seems to me. Duh. Here.
Social engagement. I do agree. And I have been very bad on that. Okay, I have to acknowledge that is not my strength. But we need to build the social basis. If you analyze what gets a priority, and there is a theory around it and evidence around it. Okay, there are about 5 different dimensions for something to gain priority. But one critical one is having a social basis. With Marcela Tamayo and with people in Mexico, we are working. Just imagine, we're working on an epidemic that is intoxicating 17% of our children under 5 years of age. 17% with lead intoxication. Why? We don't have an insurrection. Nobody cares. Is that true that nobody cares? We have not been able to build the social awareness that he wants to build, the personal awareness, the empowerment. We are not empowering the people, and we are not building the social awareness to say, we need this. We have to have this. And we're having children permanently damaged. Permanently damaged. 1,500,000 children annually being damaged because of this. And we're not, so I agree. We have to work on that part. And it's dramatic, and we have to do it.
Thank you for such a creative lecture. We've spent a lot of time thinking about the social determinants of health and increasingly on the commercial determinants of health. But this lecture has inspired me to think about the regulatory determinants of health. Given that, what is the single most important legal structure or policy that you would want to put into place so that agencies like the FDA and CDC and NIH are protected from being fractured in their independent decision-making and regulatory activities by the federal government?
Again, I will not give you the answer, I'm sorry.
You're a
I have not a
professor.
magic bottle. But I will change your wording. I do not believe in commercial determinants of health. I do believe in commercial forces against health. And that's a different thing. Okay? If you think about social determinants of health, you know the inequities, you know the poverty, and so on and so on. Here you have active forces fighting health. Okay? So we need a response, an according response. If somebody is fighting you, you have to fight back. You have to do something about that. So commercial determinants is innocuous. Commercial forces makes you respond. So the first step is try to respond, but I don't have we can work on that, but I don't have it.